Good afternoon. First of all, thank you very much for joining this session today. I'm sorry for not being with you, but let's speak about the current status of laboratory mycology and antifungal treatment in Europe. These are my disclosures. And I wanted to start with this slide, but I don't really think it's necessary, as we all in TIMM know which are the main risk factors and the main circumstances the patients have before getting invasive fungal infections. But what is important, it's the part below, because with this research, what we want to know is which are the tests that are available for diagnostics, which are the drugs that are available for treatment, and then based on that, inform and guide health professional, patients, and policymakers. So in the diagnostic and the treatment recommendations that are published every now and then, we hear or we read frequently terms like microscopy, culture, antigen test, antibody detection, or PCR. But one thing is what it appears in the recommendations, and another thing is what we can actually do directly in our sites. And the same occurs and happens with the treatment recommendation. We know that deoxycholate amphotericin B is something, well, it's a no-go. Flucytosine, it's there, but sometimes it's not really available. Liposomal amphotericin B is one could say, the good amphotericin B. And then we have also isavuconazole, fluconazole, etc. So basically, for this research and also for the ones that are coming afterwards, there was a data collection through a survey, an online survey that was made available. Even if you scan it now, you can provide information or update information from your institution. This survey, this link was disseminated through contacts, usual contacts, also through ECMM and ECMM. But there was one thing: we wanted to not to let any blank space in our map. And for that, we had to go for the small picture. The small picture meaning that we had to go looking for specific publications where we could find mycologists in the non-so-popular countries, so to say. And then also we distributed the link through our social media, LinkedIn and Twitter, which actually it's accurate as still was Twitter back then. So I won't go any in detail in this slide, but the whole idea started in Latin America and the Caribbean. Afterwards, it developed to Africa, Eastern and Southeastern Europe, the whole Europe, and Asia and the Pacific. And basically, based on this, the session is structured. In the case of Europe, we collected information on 388 institutions from 45 countries. As you can see, the only gap we found was Luxembourg. Actually, now that's already solved, and in the poster there is on the Benelux, you can find information on Luxembourg. And we divided the countries in 3 groups based on their macroeconomic data. We have countries with a GDP over $45,000, which are in the darkest blue. The countries with a GDP of 30 to $45 in the, let's say, normal blue. And then in the lightest blue, we have the countries with the GDP lowest than $30,000. And the first question we were asking was regarding the perception of the incidence. I mean, we were speaking to trained and acknowledged mycologists, so it was easy to ask them, okay, how big or how relevant is the invasive fungal infection incidence in your institution? And we can see that for most of them, it was either moderate, low, or even very low. And we also asked for most frequent pathogens. Someone could say that it's similar to the WHO fungal priority list, and indeed it is. I mean, in this case, a bit more simple, and actually it was released in parallel. And we can see how for most of the participants, Candida species were the most relevant ones, afterwards Aspergillus, and then we have Mucorales, and at a similar level, Cryptococcus and Fusarium. And regarding the access to microscopical tools, this, at least one, was accessible in almost any institution, regardless of the country, and it was used either, or like mainly always, to often, and very unfrequently it was never or rarely used. And now we will start seeing stars. I mean, the star means that there is a statistically significant difference between the three country groups. And here we can see how there is in the access to chalcofluor white, which is more accessible in the countries with the highest GDP. Overall, China, India Inc. is the one most accessible overall. Regarding to cultures, it's very frequently available. We can see in the very left, but still there are statistical significant differences in the access. And this we can see afterwards in the rest of the items analyzed in the species identification, more frequent in the countries with the highest GDP. And then we can see how biotech and biochemical tests were more frequently used with or in countries with the lower GDP, and DNA and MALDI-TOF or DNA sequencing and MALDI-TOF MS, it was more accessible in countries with a higher GDP. For antibody detection, we are in this moment speaking about the most novel tools, and somehow makes sense that the access is more accessible based on how big or how elevated it's the GDP of your country. You see there are stars in the global access and also in the tests for Aspergillus, Candida, and Histoplasma respectively. For antigen tests, we can see the same thing, a general, in this case, a better access, a general good access, and normally there is a replication, like it's a copy and paste, so to say, between the access to any antigen test and the access to a certain, or at least one Aspergillus test. In this case, includes ELISA and also the lateral flows. And afterwards, the most common one is Cryptococcus, then beta-diglucan, and then the access for Candida and Histoplasma is a bit more limited. For molecular tests, in this case specifically PCRs, we can see exactly the same thing, how the GDP determines the access institution will have to, to the molecular tests. And now we go to the antifungals. We can see how whenever an amphotericin B was available in most of the cases, except for the countries with the lowest GDP, this was at least liposomal amphotericin B. And then there was a bit more reduced access to deoxycholate and also to lipid complex. Regarding the azoles, here we see something we have observed before, a copy-paste, so to say, between the access to at least one triazole and the access to fluconazole. But then if we look for the access to mold-active triazoles, then the most frequent one is voriconazole and then itraconazole. In all the cases, as you can see, there are statistically significant differences between the different countries. And then we have posaconazole, which is similar to itraconazole or voriconazole, and then finally isavuconazole. In the countries with the largest GDP, it takes, or it's around 80%, but if we look for the data in the countries with the lowest GDP, the light blue, we can see how it barely reaches 20%. And for echinocandins and other antifungal treatments like flucytosine and terbinafine, we see an acceptable, especially in the countries with the largest GDP, access to echinocandins, mainly caspofungin, and in the cases of flucytosine and terbinafine, in the largest, or in the countries with the largest GDP, it's around 70%. But then, as long as the GDP decreases, the access to these two drugs really drops down. And then we have therapeutic drug monitoring. Here we can see how whenever there is access to therapeutic drug monitoring, this is definitely voriconazole, which is fine, but still there is quite a room for improvement. And definitely there is room for improvement in the access to flucytosine, itraconazole, and posaconazole, especially in the countries with the lowest and the, one could say, middle GDP. So with this, we come now to the conclusions. And the first one is that while Europe is generally well equipped to handle invasive fungal infections, some institutions do lack access to certain diagnostic tools and antifungal drugs recommended by the WHO. There was actually one session speaking about the essential list for diagnostic and for treatment of well, I mean, like the report from the WHO is in general, but there was on Friday, if I'm not mistaken, there was a session specifically on these aspects applied to fungal infections. There are actually substantial differences based on macroeconomic situation of the country, and we have seen them in here, and still there are limitations that need to be overcome. And probably this we can do if we work together within Europe, not European Union, but Europe as a geographical term. And that would be the best choice for our patients, especially considering how the mobility is in our continent. If you want to have the full details, you can scan this QR code and you will have access to the full publication. And then I would like to thank to all the participants in this survey, Faristos Poli, and would like to invite you to visit today the even posters, which are the ones for Argentina 132, Nordic countries 160, Benelux 254, and Italy 166, and the Balkans 158. And I would like to invite you also, and I hope to see you in Bilbao, which will be personally a great pleasure as I'm originally from the area. Thank you very much. And as we say in the Basque Country, eskerrik asko.